Welcome to section 34 of the Falcon Review Online. This section we're going to discuss the pelvic viscera. A 35-year-old female is interested in becoming pregnant, but they're having difficulty and she has a history of multiple miscarriages at around 5 months. Upon examination, you notice that she has a uterus that is not properly positioned. You explain that the maintenance of the uterus in its proper position can be important for both conception and the ability to carry pregnancy to term without complication. What is the more common position of the cervix in relation to the vagina and the body of the uterus in relationship to the cervix? Hopefully now you'll remember that it was anteverted and anteflexed. We'll discuss this a little bit further as we go throughout this section. Here you can see the pelvic viscera of a female in place with the peritoneal linings covering over it. The peritoneal linings will produce two areas that will allow for fluid collections, and the lowest place in the female is going to be the recto-uterine pouch of Douglas. The more anterior, between the uterus and the bladder, is going to be the vesico-uterine pouch. This recto-uterine pouch and vesico-uterine pouch are going to be sites where fluids can accumulate and may need to be evacuated because of a peritonitis. In the female, simply inserting a needle through the vaginal wall and into the recto-uterine pouch would allow for a withdrawal of those fluids from that low point of the peritoneum. Here we can see the uterus positioning. Now the uterus is not tethered in a solid position. It will move depending on several scenarios, such as the fullness of the bladder. However, it does have a fairly usual position, which we've discussed already as being anteverted and anteflexed. The anteversion is in reference to the cervix, which is going to be in the front half of an axis that goes through the cervix and through the vagina. And the anteflexed is going to be the body flexing over and towards the bladder. The interesting portion of this is that if you have a retroflexed cervix, pregnancy can be difficult. If you have a retroverted uterus, there's too much pressure from the developing fetus in around the 6 and 7 month periods, which can cause premature softening of the cervix and spontaneous abortion. Let's look at the uterus in cross-section so that we can start to see some of the functional features of it. We've already looked at a similar one in the earlier modules, so we'll remind you that we have the fundus, the uterine cavity, and an internal and external os of the cervix with the cervical canal between. Then there's going to be the vaginal process, which will wrap around to the very distal portions of the cervix. It's going to be predominantly smooth muscle, except in the lower quarter, which is going to have some innervation from the pudendal nerve and some somatic control of that. Around the cervical opening is the fornices of the vagina. There are two lateral, an anterior and a posterior fornix, and it's through that posterior fornix that you can gain access to the recto-uterine pouch of Douglas. In the walls you can see the horns, which would be the uterine tubes reaching through the fundic region of the uterine wall. The portion traveling through the wall would be the intramural portion. Then there's the isthmus, which is a constriction, the ampulla, where fertilization occurs, and then the infundibulum. Fimbria on the end of the infundibulum will help to guide the oocyte into the fallopian tube. A couple things of interest with the ovary that we haven't discussed before is that on the lateral aspect of it there's a suspensory ligament, which is really the ovarian vessels and nerves coming down from the abdomen to supply the ovary. Remember, the arteries come off of the aorta, and the veins will go back on the left to the renal vein and on the right to the IVC. This is not really a ligament at all, just these vessels covered with peritoneum. On the medial side of the ovary, we have the proper ovarian ligament, and that is going to be the first proximal portion of the remnant of the gubernaculum. And the gubernaculum is the component of the ovary that will help it to descend down into the pelvis. Then it will anchor to the uterine wall and make a turn and come off as the round ligament of the uterus, which will then go through the inguinal canal and anchor into the labia majora. The cardinal ligament will help position the cervix, and it's going to have a fibrous connective tissue condensation of endopelvic fascia, and the vessels that are going to be coming in here will be the uterine vessel off of the anterior division of the internal iliac. And in association with that, there's going to be closely running ureter. And when you're ligating the uterine artery, you don't want to ligate the ureter instead, because that ureter needs to continue around to the front of the bladder. It's time to try another question. There's a 45-year-old female that has uterine fibroids, 5 centimeters in diameter and pressing on the urinary bladder, causing urinary frequency. Which of the following is the most likely location of this leiomyoma? The answer to this one is the subperitoneally located anterior surface of the uterine body, and this puts it in anatomical apposition to the bladder itself for providing pressure. Let's look at the positioning of these from above. Here we're looking down on a cross section of the abdomen, and we're looking into the pelvic cavity. You can see the descending colon with the sigmoid colon and rectum, as it will come around and be behind the uterus, which is now flexing over top of the vesicle or the bladder. The ovaries are projecting posteriorly along with the uterine tubes, and the round ligament of the uterus is projecting anteriorly towards the deep ring around the inferior epigastric vessels on the anterior abdominal wall. Strapping off of that is the broad ligament of the uterus, and that's one of the ways that the uterus is loosely held in position in the pelvic cavity. Posteriorly, you can also see coming off of the top of the cervix those uterosacral ligaments that will help to hold it in place as it anchors it down posteriorly. The space in between is going to be the vesicouterine space, and then in behind the uterus is going to be the rectouterine space. One of the clinical things that you should be thinking about in relationship to the anatomy of the pelvis is going to be ovarian cancer. Remember, most of the cancers of the ovaries are epithelial carcinomas or germ cells. Over 15,000 deaths per year are still happening with ovarian cancer, and one of the problems with it is they tend to spread very easily into the local peritoneum, the rectum, or the bladder, because they're so superficial when they start forming on the epithelium of the ovary. This is going to cause more generalized problems with the feedback and the referred pain that they have, and oftentimes they go through as early detection as missed. Also, because they're associated with that midline abdominal pain at the T10 level from where they descended down in the abdomen of the embryo, oftentimes this is misdiagnosed or missed altogether, similar to the way that we talked about pancreatic cancer earlier. The older you get, it's going to become more common over 50, or it's going to be more common if you've been on any kind of medication or anything that would prevent ovulation. The more the ovulation is suppressed, the more chances of ovarian cancer. And below this laparoscopic picture, you can see an ovarian tumor. Here's an image called a hysterosalpingogram, which will allow you to visualize the female reproductive tract. This is going to be a dye contrast substance injected in through the vaginal tract into the uterine cervical os, and then it will trace out along the fallopian tube, which will allow you to look for blockage or any kind of injury that would prevent an oocyte from moving through the fallopian tube down into the uterus. The blockage could cause the movement of the sperm or the egg. This will also help you find problems inside the uterus where you may have fluids that don't go along the wall because there could be a leiomyoma. Let's try another question. A 55-year-old woman underwent a total hysterectomy. During ligation of the uterine artery, what adjacent structure must a surgeon be careful not to injure? I think we've given this one away a little bit prior, and the ureter is the structure that you have to be careful of. One of the ways they'll use a memory tool to remember this relationship is that you have the red bridge with the yellow water underneath it. I always think of the London Bridge, which is painted red and has that nasty yellowy brown water underneath. In a hysterectomy, that vascular structure called the uterus is taken out, and there's several approaches to this. You can have an open abdominal approach or a laparoscopic approach, and they can take this out transvaginally as well now. This cuts down on healing time and scarring, of course. You can also get the oophorectomy with it. If this happens, it will automatically induce menopause because the hormonal influences of the ovary will be lost as well. In the picture up top, you can see how vascular the uterus is, and you can see the close relationship between the ureter and the urinary or the uterine artery. And here we've expanded that view to show that relationship. So one of the reasons that you're going to have hysterectomy could be fibroids, which we've discussed earlier, that will present with pain, fullness, or the abdominal gas, spotting and bleeding, and urinary frequency. Then you can have endometriosis, an infection of the endometrial lining, which can't be cured otherwise and needs to be taken out surgically. Uterine prolapse, where the uterus will lose its positioning and drop into the vaginal canal and sometimes out through the vestibule. Or cancer of the uterus, cervix, or even the ovaries and uterus. The vaginal bleeding that persists despite treatment, so heavy menstrual cycles, and chronic pelvic pain. Some of the other structures that you'll need to cut and be mindful of while you're removing a uterus is going to include some of the broad ligament, the round, proper, cardinal, and uterosacral ligaments, all of which we've discussed in prior slides. Here you can see pictures of the leiomyoma and the different types of uterine fibroids that are associated with it. These are benign, very hard growths that affect 1 in 5 women typically over the age of 30. They can be submucosal or subserosal. The submucosal fibroids will grow into the uterine cavity and are thought to be the ones responsible for a prolonged and heavy menstrual bleeding. They can be a very serious problem for women who are attempting to get pregnant. The subserosal fibroids grow outwards from the center, and the uterus can then have fibroids which will push on the bladder, as we saw earlier in one of our questions. It's the anterior growths that are more common, but if they grow posteriorly, you can have a similar pressure put onto the rectum, leading to constipation or an effect on the spinal nerves that can give backache or even leg-associated pains. Let's talk about cervical inspection, since many of you will do these several times during your career, and there's a few things that you should be aware of. One of the things that you can key in on for the USMLE Step 1 stems is that the nulliparous cervix is at more risk for cervical cancer. So that may be something that you hear about in the history for questions. Also, there's going to be cervical cancer symptoms that you need to be aware of. There can be vaginal bleeding after intercourse. That's going to be a result of the vasculature around a cancer, which makes the tissues friable. There's going to be watery, bloody vaginal discharge that may be heavy and have a foul odor associated with it if the cervix has started to undergo histological changes. And then there could be pelvic pain or pain during intercourse, which will be a sign of that. During the physical examination, you may elicit some serious pelvic pain and have blood on a withdrawn gloved finger. Let's move on to the male reproductive tract. Here you can see the dissection of the major portions of the male reproductive tract with the urinary bladder and the posteriorly located seminal vesicles off to the side, with the ureter coming in from the lateral position and the vas deferens dilating out and over top of that into the ampulated portion. Remember that the seminal vesicle as well as the ampulated portion of the vas deferens are remnants coming from diverticula of the metanephric duct. The prostate, which should be about walnut sized, is sitting on top of the perineal membrane. And then in the deep pouch of that perineal membrane is going to be the bulbourethral glands, which in the dissection can be seen just underneath the prostate. Then you can see the erectile tissues, which we've discussed in the external genitalia component with the crus and the bulb. The spermatic cord, seen here ensheathed in all of its wrappings and on the other side dissected away, has the vas deferens in it, as well as the testicular vessels. Remember, the testicular vessels will come off at the T10 level and go back to the aorta for the arteries and back to the inferior vena cava or the left renal vein for the veins, the same way that the ovarian vessels did. That ductus deferens will come up and become an ampulated portion, which will then connect to the seminal vesicle. As they come together, they'll have an ejaculatory duct that heads through the prostate and empties into the prostatic urethra. Here's another view with the lit up bladder. Ductus deferens and seminal vesicles are easy to see. The ureters have been cut away in this case, and then the prostate can be seen both there and in that vesiculogram, which is similar to the hysterosalpingogram that we saw earlier for the female. There in the dissected view you can see the ejaculatory duct, which would come through the substance of the prostate. Let's discuss some of the clinically relevant zones and lobes of the prostate. There's now two ways of dividing up the different areas of the prostate. One is more pathologically oriented and the other is more anatomically located. I think for the USMLE Step 1 you probably want to have a rough idea of both of them, but the pathologically oriented one will be more important because it relates more specifically to the prostatic cancers and hypertrophies. For instance, 1/3 of the cancers will be located in the transitional zone, which is around the prostatic urethral region and the ejaculatory ducts where it empties into it. 2/3 almost of the cancers will be located in that peripheral zone, and then a few will be found in the central zone. The fibromuscular component anteriorly has very little tissue in it and is not that susceptible to either. If you look at the anatomical breakdown of these structures, you can see that there's the urethra traveling through, which has an anterior component, which is fibromuscular, and then the lateral components would go through all three of the previous zones that we talked about pathologically, and then posteriorly behind the ejaculatory ducts is the posterior prostate, and in the middle portion will be anterior to the ejaculatory ducts. Most commonly it's the posterior portion and the mid portion that are responsible for the benign prostatic hypertrophies that will close down the urethra and give males that going problem. The equivalent of the prostate in the female are going to be the paraurethral glands, which will secrete acidic substance into the urethra to help protect it from external infections. A little bit more about the prostate with cancer and BPH. BPH is going to affect most older men. The older you get, the more chance you have of getting a benign prostatic hypertrophy, and it's going to give you a couple symptoms that are red flags and questions. One is urinary hesitation, and two is urinary frequency. And because the prostatic urethra is compressed, there's a difficulty in voiding. We had an opportunity to look at the new way of dealing with prostatic hypertrophy or even cancers using a green light laser TURP. And this method is going to be the transurethral removal of the prostate. And what's going to happen with this is a high-powered green light laser can be passed through a cystoscope and then used to vaporize the prostate all the way out to the fibromuscular sheath that encases it, and thus can preserve the prostatic plexus of nerves and vasculature while having pretty much a bloodless environment and a faster healing rate. Some of the advantages is that it's going to seal the vessels as you laser them, and essentially this will help prevent the problems with healing as well as impotence that can be associated with it. The downsides of it is this laser beam is incredibly powerful, and if it's held in one spot too long, it will burn right through the abdomen. Prostate cancer is going to be a very common cancer for males, and most males should have a suggested check after the age of 40, and it can be a slow-growing and symptom-free cancer for quite some time, but by regular checkups there is a preventive measure. The metastasis of prostate cancer is problematic and is something that's sometimes tested in the USMLE questions. What they want you to know about this is that the prostate has connections in the pelvis back to the sacral vertebral plexus, which again, we reminded you earlier, is a valveless system that can carry those mets into the vertebral canal and up into the cranial vault. This is showing the digital exam of a prostate with a benign hypertrophy. You can see that posterior prostate has been hypertrophied in this drawing, and it is closing off the prostatic urethra. In this testicular torsion, the spermatic cord is going to be twisted. Remember, we talked earlier about the fact that it can be twisted around the absent gubernaculum testis or around a loose gubernaculum testis, and there's really only about 12 hours before this starts to die. Incredibly painful, and it can occur in fetal development as well with the neonatal torsion, which can cause a testis to actually vanish from the embryo itself. So they can be born with one testicle in their scrotum because of these torsions that occur during development. That's called monoorchism, or the single dingle. The varicocele we've discussed earlier. This is just a image to show the dilation of these varicosities in the pampiniform plexus. And remember, what was the key feature that this could lead you to is that there could be renal failure and blockage across the left renal vein, or there could be a nutcracker effect as the renal vein is coming across from the superior mesenteric. So an aortic aneurysm can compress that against the superior mesenteric, or there can be some bowel involvement as it crosses the duodenum. All sorts of things that can cause dilation, especially of the left varicocele. Now we'll discuss some of the development of the structures of male and female reproductive systems. We discussed earlier and looked at the fact that these primordial germ cells get folded into the dorsal posterior aspect of the embryo with craniocaudal folding, and that's going to allow them to migrate, so to speak, into the genital ridge. There's some genetic issues that go on with the germ cells, and of course they've already been formed, but one of the genetic links that we'll talk about at this time is the Turner syndrome. This is something that's tested regularly, and it turns out that the genetic code for these girls is going to be 45XO. This means that they're girls that are missing one of the X chromosomes, so they tend to not be able to develop all of the regular driving factors, which requires 2 X chromosomes. There's usually a short webbed neck with thin ovaries, and we've discussed the fact that they have widely set nipples and a wide chest plate. In the Klinefelter syndrome, similar disjunction problems where there can be at least one extra X chromosome, so XXY. These end up being boys with X chromosomes that are extra, and they get a little bit of feminization occurring. They tend to be tall, gynecomastic, and have low levels of facial hair or the secondary sex characteristics of a developing male. This usually means that they have low testosterone levels, a small testis, and